Thank you all for joining and welcome to our webinar, Mental Health and Climate Change, Implications and Equitable Solutions. Before we begin, all of us at the Medical Society Consortium on Climate and Health respectfully acknowledge that our advocacy, education, and learning across the country takes place on the occupied and unceded lands of many Native American tribes. To acknowledge this land is to recognize its long history and our place in that history. It is to recognize these lands and waters and their significance for the peoples who lived and continue to live in this country, and whose practices and spiritualities were, are, and shall always be tied to the land and the water. Today's webinar is the seventh in our 2023 Climate Justice webinar series as part of the Climate and Health Equity Fellowship Program. The CHEF program recognizes the need for more diversity in climate and health leadership and a sharper focus on equitable climate solutions. The goal of the fellowship is to empower doctors of color from populations that face greater burdens from climate effects and are underrepresented in medicine to become leaders in climate and health equity education, advocacy, and policy solutions. I'm Dr. Shanita Johnson, the Climate and Health Equity Fellowship Director. Also joining me from the consortium to run this webinar is Program Assistant Carissa Peters. Carissa will be available through the chat to answer any technical questions during this webinar. Our other team members on the webinar are Dr. Kimberly Williams, Program Manager, and Jordan Curry-Carter, Program Manager. The webinar series is hosted by the Medical Society Consortium on Climate and Health. We will put the link to this website in the chat and also a link to our fellows page. This webinar is held for 1 hour on the second Friday of each month from 3 to 4 p.m. Eastern Standard Time. Today's webinar will be recorded and made available on our website for future viewing as part of the Equity Resources page on the consortium's website. This year, we are pleased to offer CME credit for our webinars. Instructions on obtaining credit will be provided at the end of the webinar. Today, we are really honored to have Dr. Katrina Peters, Clinical Professor of Psychiatry at UCSF and Region 6 Trustee at the NMA, National Medical Association, and Dr. Carissa Cabán, founding member of Climate Psychiatry Alliance and CrearConSalud, Inc., an associate professor of Florida International University. Rather than using our time to provide further description of their impressive work, we are placing links to both of their bios in the chat. As a healthcare provider, it is important to consider the role that healthcare systems and providers play in regard to climate and health. In this webinar, Dr. Katrina Peters will discuss the impacts of climate change as it relates to mental health, including increases in violence, effects on psychiatric medications, and impacts to our most vulnerable populations. Dr. Carissa Cabán will share her community work in climate change, social inequities, and the link to mental health, including her work in Puerto Rico. The format for today's webinar will be two 20-minute presentations by our speakers, followed by 10 to 15 minutes of Q&A from the audience. We ask that you put comments, links to any resources that you recommend, or any questions that you may have for the presenters in the chat box at any time during these presentations. We will certainly get to as many of the questions as we can during the Q&A period. Please do remember to keep yourself muted so we are not interrupted by background noise. Dr. Peters, please do begin, and thank you for joining us.
Thank you. Good afternoon, everyone. I'm going to talk about the mental health challenges due to climate change, and particularly focus on people of color and other vulnerable populations. Next slide. I have no disclosures. Next slide. Climate events impact mental health. When we think of climate events, we can think of them as acute events such as hurricanes, floods, wildfires, subacute or long-term changes that may last months or years, such as drought, heat waves, stress, and long-term environmental changes, such as higher temperatures, rising sea levels, permanent displacement, and existential threats. Next slide. Each form of climate change can result in varying degrees of economic losses, property damage, loss of income, loss of employment, especially agriculture and fisheries. Threats to health and well-being associated with extreme weather events, injuries and deaths, spread of disease, population displacement, loss of attachment to the natural violence, and you can also cause social conflict and intergroup violence. Next slide. The impact of acute climate events can have many effects on people's mental health and states. We've noticed increased rates in anxiety, mood disorders, acute stress reactions, PTSD, sleep disruption, suicide and suicidal ideation, grief reactions, decreased sense of self and identity from a loss of place. These mood disturbances can last and linger for months and years after the event. The risk factors for developing mental illness are increased by the magnitude of the event, exposure to injury or death of loved ones, females, younger people, lower socioeconomic status, those with less education, minority ethnic status, psychiatric history, inadequate family or social support. Particularly vulnerable are children, the elderly, the chronically ill, mentally ill, disabled, pregnant persons, and first responders. Next. Heat impacts can also increase suicide. There have been studies that have shown that suicide increases with the temperature 0.7% in the US and 2.1% in Mexico for each 1 degree Celsius over the monthly average temperature. This projected, because of increase in temperature and climate, is projected that 21,000 more people will suicide by 2050. This is across all socioeconomic levels. There's also an increase in interpersonal and group violence that we've mentioned before, and you can also see impaired cognition and concentration and insomnia. Next slide. Heat can have an impact on many of our body functions. Heat suppresses thyroid hormones, can cause functional hypothyroidism, lethargy, low mood, cognitive impairment. It stimulates growth hormone and prolactin, which can also cause lethargy, increases body dehydration, which can also cause deterioration of cognition. People with pre-existing mental illness are especially vulnerable to heat stress. Exacerbation of illness, especially those with dementia, schizophrenia, and substance use due to poor thermal regulation associated with psychotropic meds and heat-related cognitive impairment. Next slide. Those with severe mental illness may find an increase in emergency department visits and hospitalizations during heat waves. And Wang found that there was an increase for psychiatric patients during these extreme heat events versus our non-psychiatric patients. Bolkama also found that there was a triple risk of deaths due to heat stroke for mentally ill. Some of this is related to the illness themselves, and some of it is related to the effects of heat with people who are concurrently taking psychotropic medications. Almost all psychotropic medications affect thermal regulations except benzodiazepines. So that includes anticholinergic meds, amphetamines, beta blockers, lithium, serotonergic medications, and antipsychotics. Next slide. Other impacts of extreme temperatures have noted that there has been an increase in violence and conflict during extreme heat. That's been found by at least 2 researchers, Anderson in 2003 and Sang in 2013. Children and women are vulnerable to increased domestic violence. The relationship between hot weather and crime is linear. As it gets hotter, people get more aggressive. There's an increase at 4% between individuals and 14% between groups. Next slide. The impact of acute events, weather events on residents in low to middle income countries, especially vulnerable with increased exposure to extreme weather events, places with high levels of poverty and lack of access to services. Between 25 to 50% of those exposed to extreme weather events will experience negative mental health outcomes. For an example, and I know my colleague is going to be probably talking much more about those events in Puerto Rico, but one study did find in 2017 that there was a 16% increase in suicide rates from 2016 and a 26% increase in the number of suicides. 6 months after, they found 74 households, 54.6 scored in the range of major depression, 48.6 general anxiety disorder, and 41.9% PTSD. Another study found that the rates of PTSD was higher among those who were displaced from Puerto Rico and living in Florida. Next slide. Other events of subacute climate events. Obradovich studied the relationship of historic climatic conditions and mental health, 2 million random US residents between 2002 and 2012. He found that the monthly temperatures greater than 30 degrees Celsius or 86 degrees Fahrenheit increased the probability of mental health difficulties by 0.5%, and 1 degree Celsius of 5-year warming was associated with a 2% increase in prevalence of mental health issues. So basically, an increase in temperature increased the probability of mental health difficulties. Increased heat also increased aggressive and criminal behavior, domestic violence, substance use, assaults, homicides, and suicide rates, especially in men and older adults. Next slide. Drought, which is also a climate event, a subacute event. Prolonged drought due to climate change can lead to more psychosocial distress, general anxiety, depression, and increased suicide in rural areas. Older adults are particularly vulnerable. Indirect impacts of climate-related events. You can see economic loss, a migration pathway, community well-being, impacts of physical health related to mental health. For example, there was a 48-year-old farmer who came from India, immigrated to Kentucky 20 years ago due to drought destroying his farm in India. He presented with suicidal ideation after the drought was destroying his crops again in the US. Next slide. The impacts of long-lasting climate events. There's a concept of existential threat, which is the psychological distress and anxiety about the future. The American Psychological Association has seen a worsening state of environment is already causing a sense of stress and can cause despair and hopelessness and can contribute to psychotraumatic syndrome. Complain of co-anxiety, eco-anxiety, eco-paralysis, and solastalgia, which is the distress and isolation caused by the gradual removal of solace from the present state of one's home environment. So we're even getting brand new types of syndromes with the worsening of climate events and impact on our environment. Young people, especially in high-income countries, are especially vulnerable to this psychological distress and anxiety about the future. Next slide. Impact of mental health of children. Climate change is leading to an increase in child's risk of a depression, anxiety, or PTSD. Air pollution from burning fossil fuels are linked to more symptoms of anxiety and depression. There was a study of 400 young people aged 8 to 16 directly affected by Hurricane Katrina. 25% suffered PTSD, but most symptoms declined by 2 years later. There's a small number who had persistent PTSD symptoms after 2 years. Next slide. The impact of climate change on Black Americans. One, institutional racism can play a factor, contributes to environmental injustice and climate injustice. So often communities that are impacted by many of the consequences of climate change also are impacting their environment. For an example, in Hurricane Katrina, New Orleans' 9th Ward lost 80% of African-American homes. They were never rebuilt, and that area was converted to a green space. Hurricane Harvey, which happened in Houston, Texas, again, there was impact more in many lower socioeconomic communities because they were of lower elevation and there were lower services, so there was more destruction. An example, 1995, which almost 20 years ago, this Chicago heat wave, there were 740 deaths in 1 week. Many were low-income elders who could not afford air conditioning, and they were afraid to open their doors or windows due to fear of crime. Next slide. There's also impact climate change in Latinx communities, climate migration impacts, especially from Central America and Mexico, the effects of extreme heat on the well-being of outdoor workers. There are some states, for example, in California, where there are laws about agricultural workers in the heat. They're supposed to have certain kind of breaks so that they can have adequately hydration and preparation to avoid dehydration. Not all communities and states have these kind of protections for outdoor workers. So you can still see, in addition to the physical strain of being outdoor workers, you can also see exacerbations of chronic mental illness, increased risk of new onset PTSD, depression, anxiety, sleep disturbance, substance use, and attachment disorders. Next slide. On the indigenous community, it's also vulnerable to the effects of climate change due to forced relocation of tribes to reservations on less desirable land. For an example, a lot of the Navajo lands that are in Arizona have very little water. People have to basically cart water from many miles away. They bring them in trucks. So this further makes it difficult to have a good livelihood due to their restricted access to water. Permanent drastic changes to the way of life impacts mental health, again, can lead to increased substance use, sexual trafficking. Indigenous women and girls have a murder rate 10 times the national average and face greater rates of physical and sexual violence than any other racial or ethnic group in this country. In 2017, there were 5,700 reports of missing and murdered Indigenous women and girls. Next slide. Trauma from wildfires. Here in California, that's been very common. And with the people have had complex repetitive trauma. There was an Oakland fire in 1991, which I suffered under and was fortunate to survive, but I had no idea at that time all those things were related to climate change. Paradise, California, completely burned in 2018, the Dixie Fire 2021, and the fires keep coming every year. It's not uncommon for people to have been involved in one destructive fire and then moved, and then there's another fire there later. Some people have lost multiple homes because of this, due to the wildfires. Population migration, the UN found migration due to climate change events happening each year since 2008, averages more than 20 million people forced to move due to floods, storms, wildfires, droughts, coastal erosion, and extreme temperatures. Next slide. The COVID-19 pandemic has had an adverse impact on mental health that's been exacerbated by climate change. So although we're formally, quote, outside of the pandemic, people are still suffering from many of the impact that the pandemic had on their environment and their mental health, and it's been exacerbated by the other stresses from climate change. Next slide. How can we respond and what interventions? One, there's clinical and patient management. We can do psychoeducation with patients and families. Agencies and clinic preparedness need to be aware about the increased mental health needs as it is related to climate change and the subsequent problems that have developed. The systems of care need to interface with public health and other agencies. And also advocacy is very important, because without advocacy, we will not be able to develop all the policies that are needed in our legislation and in our administrative state and national government for us to be able to tackle all of these problems. Again, I thank you very much, and we will wait for questions.
Thank you very much, Dr. Peters, for this enlightening presentation. We will now hear from Dr. Carissa Cabán. You may begin.
Hi, good afternoon, everyone. I hope everybody can hear me okay. Before I get started, I just have to acknowledge what's going on in the world right now and just say that, you know, it's very sad to know that innocent lives are being lost at this rate and this level of terror. And I hope that I have a few minutes just to explain how I think that inequity that manifests in war and violence is not that different from the inequity and the systemic oppression that has led to climate change. So I'll talk about that hopefully at the end. I'm gonna go ahead and project my slides. Give me 1 second. Okay, they should be loading. Okay, I think everybody can see them now. So I'm just gonna talk a little bit more about some of the concepts that my colleague has already explained. I'm not gonna go so much into you know, all of the relationship in between climate change and mental health, but just trying to talk a little bit about my experience and how I've had the privilege and the opportunity to work in some projects in which I've learned a little bit about how to address the social determinants of mental health in combination with addressing the impacts of climate change, which I consider and many of my colleagues consider to be yet another social determinant of mental health and health. So I don't have anything to disclose. I don't work with any companies or anything like that. So I just wanted to start by taking a few minutes to use and about my experience with this topic. I mostly have learned what I know from community and educational experiences that I've had in Puerto Rico, mostly after the hurricanes of 2017, like Hurricane Maria, which was already mentioned in terms of the increased prevalence of suicidal rates. After that disaster, we also had another hurricane a couple of days before that started to affect geographically and environmentally the island and the archipelago. And then we had to deal with that other hurricane that year. I was actually living in Miami, Florida, and teaching and working in Florida International University. But we happened to be one of the primary hubs of diaspora help that sent multiple shipments, planes, and cargo of medical supplies and food and water supplies so that people could survive. One of the reasons why this was particularly difficult for Puerto Rico, besides being in the middle of the Caribbean and not being tied to the land of the United States states, is basically that we still have to put up with a very old law called the Jones Act, which also applies to other territories of the United States and also to Hawaii, in which everything has to come to us from other from ships that are actually from the United States. Most of them come from Jacksonville, in which we basically can't receive help directly from, for example, our brothers and sisters in the Dominican Republic that wanted to send ships of food and supplies to us. So they had to like first go to Florida and then come back. And I tell you that because this is one of the reasons why some of us, when we're dealing with systemic oppression and racism, we end up being sort of victims of higher carbon emissions. The process of having to do that for us increases the prices of all of the food that we get, which unfortunately is mostly imported into Puerto Rico from other places. We don't have enough agriculture to support our needs for food supplies, and more of the 80% of what we eat here comes from the US. And everything becomes more expensive for us. It has to be distributed through multiple ships. That delays the process, so it's harder to get access to local or fresh food. Even if it's coming from other places, it's usually not fresh. And also that causes a situation in which we end up sort of like being consumers of higher carbon emissions because of all of the transportation that our food needs to get to us. And that Jones Act limitation for Puerto Rico particularly has everything to do with our colonial status, for example. And that's why I mention it, because we're talking about health disparities, climate change, and health. We have a background that's very diverse in terms of race and ethnicity. We had I'm right now speaking to you from Nahuatl, Puerto Rico, which is a town that is very close to the Yunque rainforest, which some of you might know if you ever vacationed here. And this is Taino ancestral land. The Tainos didn't last long. They were exterminated already when the Spanish had conquered us. And when the United States arrived and conquered us, they were already exterminated. But we've tried to keep our traditions that come from our indigenous ancestry, and to remember and honor their legacy as much as possible, and to use many of the words that our language still carries from the Tainos. And then the Spanish invaded, and then the United States came, and both of those invasions included a lot of migration from Africa to, send slaves to Puerto Rico to work here. So that's why we also have a very strong Black heritage. So I just wanted to mention a little bit of the context. CrearConSalud is it's translated in English as Create with Health, and it's basically a nonprofit organization that I was lucky to be part of founding with many Puerto Rican psychiatrists that most of us were living in the diaspora back then in 2017. It was actually officially approved as a 501c3 a couple of days before the Hurricane Maria arrived in Puerto Rico. And we sort of became this nonprofit organization that, instead of the original mission of mental health education and decreasing stigma that we had, we also became part of the efforts of disaster psychiatry initiatives because of the connections that I had with the Miami diaspora, sending food and sending medications to Puerto Rico. We started to connect with a lot of community leaders, a lot of nonprofit organizations that were very grassroots, that we knew from different persons, and they started asking us for help with the psychological first aid needs and all of the overwhelming situations that community leaders were needing to address themselves, because unfortunately the government was not responding adequately, and they pretty much had to become doctors, nurses, first responders, and they had to do a lot of different things that they didn't really have the experience, the expertise, or the resources to do. And so we started to help with different initiatives from grassroots organizations, community leaders, and other medical and clinical professions that were trying to help in multiple ways. So I don't want to run out of time. I'm actually going to skip this slide. It's basically to point out that mental health services were desperately needed much more after Hurricane Maria, but only 18% of Puerto Ricans actually received officially federally funded mental health services after Hurricane Maria. And this information is up to 2020, but the scarcity of mental health services and healthcare services in general in Puerto Rico has gotten much worse because of many socioeconomic and political situations that Puerto Rico is going through. Some of them apply to many minoritized communities in the United States as well. Situations of corruption, racist policies, et cetera, but in Puerto Rico, we have the additional component of not having legislators or politicians that can vote for us in the federal legislature, yet the federal government controls our government pretty much. So I just wanted to point that out so that you understand a little bit of the context in case you don't know much about Puerto Rico's socioeconomic and political status. This slide is just to point out that the information that I am trying to share with you today is based mostly on community empowerment initiatives, not so much on academic work or doing, although I've published some work related to climate change and mental health, I'm not coming to you with information that's literally like produced by research studies that I have worked in. It's mostly like what I sometimes call real research, and trying to connect with people that need support and learning from them more than anything else. So these are some of the pictures of some of the initiatives that we were involved in after Hurricane Maria. The American Psychiatric Association and Foundation have been supporting us from the get-go. They actually, some of them actually sort of like told us, you need to get, official and open up a 501c3 organization. And we were very motivated by them from the beginning. Multiple other people that have supported us and other organizations. To the right, you'll see pictures of the first workshop that we offered for community leaders, which was, we also offered donations of water filters because many of the persons in that community, which was completely flooded, and many residents have lost their roofs, didn't have access to clean water at that point. I came in October. The picture on the bottom to the right is a round group, a venting group pretty much, and a session to just provide them with some psychological first aid tips and some support to address what was going on in their communities. Many of them didn't have a roof over their heads. They had tarps, or they were staying with family members. That is an alternative educational school called Peces. I actually now live less than 30 minutes away from it. And they were completely flooded, and that was, I think, almost, I would say, around a month after the hurricane, and they still didn't have water nor power at that point. And many communities didn't have water or power for the first 3 months. And my neighbor, where I live now in a rural community, told me that he didn't have power for 1.5 years after Hurricane Maria. So that's so that you have an idea about the impact of climate-related disasters that Puerto Ricans have already endured. Many persons in the world still haven't experienced a direct impact themselves, but we are, struggling with severe heat waves already, with flooding, with drought, and many other climate-related risks that have been scientifically demonstrated to be an impact product of climate change, or at least worsened, or the frequency has increased because of climate change, like with hurricanes. So this is a diagram that you might have already seen from Eco-America. And basically, I just wanted to quickly show it to point out how intersectional and interdependent the health determinants are when it comes down to thinking about the climate change impacts of health. I have worked with mostly the gray on the bottom, trying to address with different initiatives and projects those consequences that are more at a community level and not so much individual. But the most important thing is to point out how the geophysical impacts in the middle that we recognize as climate change impacts, are interdependent with all of the things that are described in the yellow. And I think that these slides have been shared with you already, so you can carefully study this diagram later. One of the things that I think is very important in the United States, at least in Miami and in New York, where I lived before, and also in some communities here, especially in the metro area and the urban areas, is social cohesion, and how important that is in the healing process and in the recovery process after a disaster, but also in the preparation at a resilience level and at a healthcare level, in terms of helping people survive emotionally when it comes down to addressing climate anxiety, addressing solastalgia, which I don't think that concept was mentioned in the prior presentation, but basically solastalgia is that nostalgia that we get when we realize what's going on, and we're just sad because we know that the environment that we are seeing and experiencing might not be the same after climate change hits. So this slide, I do want to spend a couple of minutes on. I wish I knew how much time I've spent already, but I think it's been around 10 minutes already. This is a slide that I don't think I've ever, this kind of study, I don't think I've ever seen it like sort of emphasized, like highlighted in any presentations that I've seen about community mental health and climate change. And it's from Perry and colleagues. And basically, I really like it because it points out that underserved and minoritized communities go through a series of interrelated forms of invisibility that are summarized, and the most important ones in the study are summarized in the middle, which are the causes of systematic bias. I'm sorry, the consequences. I apologize, of systematic biases that contribute to climate health risk, being very underestimated, misunderstood, exacerbated, or just ignored, mostly by people in power, but also by regular citizens that want to do their best to help in any way they can. And these underlying causes are systemic, right, and context dependent, and structural, and they are due to social political inequities. So things like lack of power and voice in most of the communities that we come from, uneven development and underinvestment, poverty, conflict, like the conflict that we're seeing around the world these days, instability at a social level and also economically. And then the impacts of climate change directly also cause more risk of displacement and instability. The biased global agendas of systems like neoliberalism, to be quite frank with you, that's my personal opinion. This is not based on the research, but it's one example that I would think of for myself. And then the underlying causes can lead to these invisibilities that you probably have recognized in your patients and in your communities. Social marginalization, which is extremely relevant for indigenous populations, forced invisibility of migrants, that's very visible in the United States, and others that are summarized there. One that applies to us in mental health and psychiatry is under-resourcing of mental health services, right? And then in some places like Central America, like here in Puerto Rico and in other places, there's a lot of uneven climatic monitoring and forecasting. So it's very hard to really get reliable information for preparedness efforts. And then the outcomes are what we usually learn about in red, which I'm not going to go through. So it's very important that if we don't really engage in the strategies on the bottom that are in blue, helping citizens that are underserved and not represented in structures of power reach out to that power, engaging in transdisciplinary, emancipatory, and justice-oriented research to promote socially just climate adaptation policy, and then greater empowerment, accountability, and transparency in healthcare systems, which is, I would say, the one that most of us that are clinicians just working individually with patients in hospitals and clinics, we can at least engage in that one without much effort. I know that the other two might be hard to engage in when we're extremely busy and we have a full schedule and family responsibilities and so forth. Okay, so this is just a summary of the different types of interventions that we can engage in. I've already mentioned a lot of them. I wanted to point out, although I know this is not only for mental health clinicians and people that are just working with mental health, but I just wanted to point out some important things that we in mental health are trying to like help people with at a community level, at a group level, but also individually. And we can actually do this work one-to-one, trying to help people feel less psychologically distant from what's going on, and connecting ourselves as clinicians and as people in the healthcare system to what's going on and how it's impacting the patients that we serve, promoting social norms in which climate action becomes a regular, needed, and valuable group experience, avoiding loss aversion, discussing what we're gaining by through climate action, helping people feel less powerless and realize all of the things that they have the power to do. And that really works very well for us with joining forces with grassroots organizations, with young folks, and with people that are doing the real work hands-on in the communities and with advocacy and activism efforts. And then for us that do more psychological or therapy work, applying the principles of motivational interviewing skills and mindfulness in the work that we do. And this actually applies to primary health clinicians and all of the specialties in which we talk to patients, because MI is a very, very effective intervention to do something as simple as helping your patients be compliant with their insulin if they have diabetes, if they can, right? If they have the resources to do that change, right? If it's up to them in their behavior, sometimes they just don't have enough money or even a fridge that has power all the time on to keep their insulin in the right temperature, right? So transformational resilience is like a sort of like a modality, a theoretical modality that I've been lucky to learn about. It's something that was developed by many colleagues, but one of them is Mr. Bob Doppelt. He's from Oregon. And basically, it's efforts in which we engage in systematic prevention processes that use the principle of post-traumatic growth, in which we help people learn from climate adversities as transformational catalysts, in which which we have to deal with, but from which we can learn, grow, and increase our well-being above the existing levels that were there before, that put some of us in a more vulnerable state to address climate change impacts. And then the most important thing about this theoretical framework is moving from the individual to the collective. And I'll talk a little bit more about that. I'm not going to go through the different kinds of elements of transformational resilience efforts. It's basically some skills that we use for different things in mental health, in terms of how to help people increase their self-esteem, become more resilient at a psychological level, et cetera, et cetera. On the right, I summarize the community workshop topics that we have commonly provided for community leaders that have requested our support to address climate change impacts, but also other situations that Puerto Rico has suffered from, like with everybody in the world, the pandemic, some earthquakes that were very severe that happened here right before the pandemic, and also during the beginning of the pandemic. And it's basically helping the communities learn how to address burnout, prevent burnout, and also address a very important concept that applies to many of us that do this work and to the communities that we serve, which is moral injury, developing the transformational resilience skills, basic mindfulness skills, just to regulate our activate our parasympathetic nervous system with very basic mindfulness practices, mild and not mild, but brief meditation practices. And then some work that has been done with the fiscal crisis that Greece went through, in terms of helping communities that were suffering a lot from the economic impacts of that fiscal crisis to develop hope. And that is something that we're also struggling with. We officially are in a fiscal bankruptcy state since 2008. There is a lot of corruption. So those models were very helpful to also address some of the other social determinants that come into play in terms of, unfortunately, making our communities more vulnerable to the impacts of climate change. These are some presencing and purposing skills that the transformational resilience model help us provide for the people that we're helping. This is just a slide to point out that we can get involved in multiple advocacy efforts. I still have a picture of the first the only medical society consortium annual meeting that I could attend to in 2018 with Dr. Holder, who's I think listening today. Hi. And other efforts that we've had with Congress. We've visited legislators, educating them about climate change and health, and trying to empower the community through different efforts, like the brochure or banner on their left, Empowering Resilient Women and Girls, which I think Dr. Holder actually invited me to be a part of that. And it was through CLEO Institute, which is a very grassroots organization that's addressing climate change in Miami, Florida, and in other areas of South Florida. So sustaining alliances with community leaders and organizations is crucial. These are pictures of different experiences that I've had with community leaders. The middle is actually a picture during the pandemic with my dad and my stepmom and a group of agricultural leaders in the town where my dad lives in. He's also one of the persons that engage in this practice, and I'm going to mention it to you in a couple of minutes. And these are other organizations that are more grassroots that work with different social justice efforts, including climate justice, that we've worked in. The bottom picture is a protest that some of my colleagues did. The lady in the middle, Dr. Huertas, is a graduate of the Colombo Public Psychiatry Fellowship like I am, and she is a very, very strong activist that has been one of my mentors, that was protesting for the inequity that the fiscal control board that was imposed by the federal government has caused for addressing multiple situations at a public policy level in Puerto Rico. I'm just going to say that could be a whole hour of explaining what's going on with that here. Very important, we try to foster community self-determination, or autogestión in Spanish, based on post-traumatic growth and helping people move beyond their personal self-interest to the collective self-interest in which we engage in supporting communities to demand human rights and essential services for a just recovery, in which we learn how to be culturally engaged and to help people and ourselves with the fear that is imposed by systemic oppression on so many of us. I'm not going to read through the rest, but basically I've worked in a lot of organizations that I'm still a part of. I've actually prioritized that kind of work over more academic, formal kinds of endeavors like conferences or panels to try to help out with a little bit of more just hands-on community work that mitigates and helps us adapt to climate change. I'm a part of an agroecology movement in Puerto Rico. I've moved to a farm. I've cut my emissions, and I'm trying to develop an ecotherapy project here in the farm where I live, because I don't think that the individual psychiatric care work that we do is enough, although I find it extremely valuable, and I'm very privileged to be a psychiatrist, and I will continue to be a clinician. I do not think it's enough to address climate mental health needs globally. So supporting adaptation and mitigation efforts in Puerto Rico has been huge for me, supporting collectives to protect natural resources, and trying to do what we can in political organizing for climate and social justice efforts. This is just a slide of a very nice article that is not online anymore, but the one on the bottom that I'm citing is, and it's basically from colleagues in the mental health field from other specialties that just point out how we can't just keep doing therapy and psychiatric treatment in a very individualistic way in which we don't address racism, cultural dynamics, and the intergenerational and ancestral trauma that most of our patients have endured. We need to start thinking a little bit more about the we instead of the I, and help them, yes, strengthen their self-esteem and think as positively as they can and all of that, because it's necessary to do that work, but also understand the context and address the systemic aspects that influence our mental health. This is just a slide to point out a little bit of the agroecology work that we're doing at a mental health level. It's a very, very powerful way when we practice community participatory agroecology efforts. It's a very, very helpful way to promote social cohesion. Okay, so I think that I am out of time, so I am just going to stop to be respectful of everybody's time. I hadn't seen the warnings. If we have more time at the end, I might just emphasize a little bit more of some of the slides that I had left. I just want to say before I finish that I think in my personal experience, and I just hope it's okay to share this with you, climate change is all about, psychologically speaking, it's all about the fantasy that many of us have learned culturally, that we are going to be happy by doing things and having things and possessing things, instead of just being alive and just being okay with just being. So there's a lot of this rush of life, this attitude of do instead of being, which is very, very applicable in the United States. And I think it's necessary for us to recognize that we are natural living beings, just as animals and plants, and we need to learn how to just stop consuming resources to try to go for those things outside that we have been, sincerely, in my opinion, fooled to believe that will make us happy. It's very, very important to change the dialectic mentality about what nature is, and the fact that it's not just a resource for humans to consume, it's part of who we are. And I think that it's very important for us to realize that if we just keep being a part of structures in which everything is about consuming and extracting instead of protecting and respecting nature, we're not going to do very well, even if we do all of these great things that can decrease carbon emissions. So it's very, very important to learn from Indigenous and Black wisdom.
Thank you very much, Dr. Cabán. We appreciate your enlightening presentation. And we have a few minutes for Q&A. And so please do put your questions in the chat box. We'll get to as many of them as we can. And we're also going to put a link to the webinar survey in the chat. So please take a moment to fill that out. We do have a question from Dr. Glover. What, if anything, is being done at the U.S. border for immigrants' mental health needs? And is there a pathway for them to get help once they are in the country? Thank you both for your lectures.
This is Dr. Peters. I would say when you talk about immigrants at the border, that's a very mixed group in terms of for what access to care that they're going to have once they come to this country. Number one, if they are legal immigrants, if they're allowed here legally, then they will have access to Medi-Cal and other kinds of services. For an example, although these were refugees that were not immigrants at the border, but many years ago, I worked in a Southeast Asian refugee clinic in Boston, and it was geared for mental health services for those refugees who had come from Southeast Asia post the war, from Cambodia and Vietnam and Laos. So there were services that were geared for them. In terms of, I'm here in California, and we have, depending on where you are in California, you have the situation where you have a lot of undocumented immigrants who may be here not legally. So I'm at a safety net hospital. I'm at San Francisco General. So we don't look at their status, but depending on what's going on politically and what people are allowed to access without challenges from immigration services, has a big impact on what access people have. There is actually a website, I was just having a look at, from the National Network for Immigrant and Refugees, NNIRR, and they actually, interesting, they had made web pages for resources for migrant communities where there are free mental health services in different communities, because mental health often people prefer or are better able to work with those who may share or understand their culture. So there were different access to Latinx. There was access to, there were people from Sudan. And as we know, recently, we've had a lot of immigrants that have come from Eastern Europe, from Ukraine. So again, what access I think that people have depends a lot on the status of their legal situation in the United States. I don't know if that actually answered your question that you were looking at, because certainly many of the people who are at the border are having an extremely difficult time. Children, there are so many things that happen, but in terms of for what care they actually get while they're there at the border is going to depend on only maybe very emergent care. And in terms of for the other trauma, like children who've been separated from their families, et cetera, again, what help they get is going to depend on their situation once they get into the United States.
Thank you so much, Dr. Peters, for that answer. We have our final question, and this is from Dr. Holder. Question to Dr. Cabán. Are there researchers evaluating these different strategies or decolonized approaches in mental health? And is there any success in incorporating these concepts into the UME or GME curriculum?
Well, there's a lot of research that's still needed. Most of the studies that talk about decolonial approaches are from psychology and also from social fields. And it's not necessarily a clinical results. So there's a lot of work to do in that sense in the United States. I am aware of some studies that have looked at it, but from the lens of climate resilience initiatives or initiatives that are particularly approaching something like social cohesion, for example. But literally like a study that could tell us that psychiatric rates of depression and anxiety or PTSD were lower because a decolonial approach was used versus a conventional approach. I'm not aware of any of them. And if they are, I would love to read them. I have not read new research studies for the last 6 months or so. I've been very busy at the farm, but I can always double check and send you something if I find anything.
Thank you. Dr. Peters, anything to add on that?
Let me see. I think, well, I agree with my colleague, but again, you know, we're really trying to work out some of these things ourselves. I mean, I'm at UCSF and they're very eager to try to see how we can improve our interactions with all different communities, and especially anti-racism and other kinds of initiatives. And I would say in a lot of this, we're still working it out. And I agree also that many of these solutions that are in traditional psychiatry and mental health, such as, you know, one-on-one therapy or even group therapy, does not necessarily address all of the needs, is not necessarily the best way for every community to interact with. And especially since we have such limited resources and such limited mental health clinicians in all kinds of levels of care, it becomes really complex and challenging for many groups, especially if they're marginalized, if they belong to different cultures, to be able to feel comfortable in accessing our mental health care. So there's a lot of work that we need to do on that, but it's a really good question.
Well, thank you both
Yes.
for outstanding lectures, and this discussion really could go on much longer. I wish we had more time, but we do need to wrap up our session. So I'd like to thank you both for participating in this webinar series. And I'd like to thank you who are our audience. I hope that you found it useful. As a reminder, these webinars are held on the second Friday of the month. The next webinar is scheduled for November 10th, and the topic is Environmental Justice with Dr. Mustafa Santiago Ali. Before you leave, we ask you to take a moment to complete the webinar survey if you haven't already. Again, we've placed the link in the chat. And as announced at the start of the webinar, we are pleased to offer CME credit for our webinars this year. To claim this credit, please follow the link in the chat or scan the QR code on the screen and follow the directions on our website. Today's activity code to claim CME credit is 13099. Again, 13099. So this now concludes our session. Please do have a wonderful day and weekend, and thank you for joining us.